Hello everyone, my name is Ishi. I'm a junior doctor from North Devon Healthcare Trust, and I'll be presenting a prospective randomized comparative audit of surgical site infections following hand surgery performed in a treatment room compared with an operating theatre. Superficial SSIs have a low morbidity and is easy to treat. Deep SSIs are associated with worse clinical outcomes, the need for hospital admission for IV therapies or additional surgical procedures. There has been an increasing shift away from utilizing the standardized sterile environment of an operating theatre in an attempt to facilitate cost-effectiveness, resource management, and as a resilient option when an operating theatre or anaesthetist is unavailable. There is lack of evidence comparing SSI rates between treatment room and operating theatre and whether field sterility is as safe as full sterility. Since the COVID pandemic, national guidelines advises wide-awake local anesthesia no tourniquet technique in treatment room for all hand surgery due to limited theatre slots. Our aims for this study was to determine SSI rates for procedures performed in a clinic treatment room setting compared with the same procedures performed in operating theatres by the same surgical team with minimal confounding factors. We performed a prospective review of all soft tissue hand and wrist procedures in a single primary centre between June 2020 and January 2021, which was cycle 1, and January to October 2021, which was cycle 2. The procedures were all randomised. Patients were not given perioperative antibiotics and no anticoagulants were stopped. All procedures used Wallant. All patients were followed up within our own team by hand therapy 10 to 14 days post-operatively, and all infections were reported directly to the surgical team prospectively. In cycle 1, procedures in the treatment room were prepared with field sterility, where the surgeon donned either surgical scrubs or outdoor clothes, a surgical hat, mask, and sterile gloves. No sterile gown was worn. Hand wash, patient's clothes, surgical site prep, draping, and instruments used remained the same for all procedures. In cycle 2, procedures in the treatment room were prepared with full sterility, which included all of the above, but the surgeon also always wore surgical scrubs and a sterile disposable gown. In cycle 1 of the 73 treatment room procedures, 2 patients had a superficial infection, 1 requiring IV antibiotics. Of the 74 operating theatre procedures, 1 patient had a superficial infection. In cycle 2, of the 66 treatment room procedures and 101 operating theatre procedures, no patients developed clinically proven infections. There were no deep infections reported in either arm. We found that SSI in hand surgery is low, whether performed in a treatment room or operating theatre if using the same sterility of gowns and drapes. We found no apparent difference in the overall rate of SSIs between the two settings. In 6 months, our department saved £500,000 using a treatment room and increased our total theatre capacity. A clinic treatment room is a safe alternative to operating theatres and beneficial in terms of cost effectiveness, resource management, and as a resilient option when there is poor access to theatres. We hope that this study could act as a pilot for a multi-centre randomised control trial. Thank you for listening.